So I'm going to be talking about why we should stop calling Gleason 6 prostate disease cancer, why we should avoid that particular word. There's been discussion for many years in the literature about this, but I think this is the first time this paper in the Journal of Clinical Oncology that a group of experts actually came out and said, okay, let's stop calling this cancer. Not like it's time for debate or is it really cancer? And this has been called the Gang of Six, amusingly, because there's six of us and we're talking about Gleason 6 cancer. But you'll see it's a multidisciplinary group. It's being led by Scott Egener, who, of course, was a fellow here in MSK. And we have a couple of urologists, a radiation oncologist, a pathologist. I'm the statistician, and Howard Walensky, you can see there is, you might not recognize the name, but he's a patient advocate. The group isn't just about rhetoric. We're not just sort of going out there and making our arguments. We're actually doing research. So this was a paper we published last year. And very simple idea. What we did was we had two cohorts of patients that were undergoing radical prostatectomy, and we had an estimate of the volume of the three types of tissue in the prostate: benign, pattern 3, and pattern 4. And then we lined that up with their PSA levels. And as you can see, that the amount of PSA that you saw in the blood of somebody, for a 1 cc increase in the amount of pattern 3 or in benign was about the same, right? In fact, there was no significant difference between the two of them. A 10-fold higher increase in the amount of PSA in the blood per additional cc of pattern 4 disease. So this is our sort of mission statement, if you like. What we're saying is that the diagnosis and management of Gleason 6 prostate disease should be based on best evidence and established principles of good medical practice, rather than be influenced by the highly emotive word cancer. And I want you to remember this little type of mission statement because we've been accused in the literature of all sorts of things, like saying that we can't do this or you have to do that. And we're like, no, what we're always saying is, let's follow good evidence and best practice. So this is an overview of the talk. The first, I'm going to say, is it even an option to call Gleason 6 not cancer, or is it just so clear that it's cancer that we shouldn't even be considering it? I'm obviously going to make the case that there's room for reasonable people to disagree about whether you call Gleason 6 cancer or not, and therefore the focus should be on the public health benefits of redesignation, the practical implications of calling Gleason 6 cancer versus not cancer. And then, of course, how is it going to affect you, right, if we do redesignate? Okay, so is it even an option?
Hey, Andrew, I think some of it is how you define cancer.
I'm going to come straight onto that. So I'm going to, this is exactly what I'm going to jump into. So this is exactly the point. So this is John Epstein, and he's saying, morphologically and genetically, Gleason score 6 is cancer. I, as a pathologist, I'm going to define Gleason 6 as cancer. Cancer is cancer. End of debate, right? Yeah, you might not want to call it cancer, but it just is cancer. And as a result of this sort of belief, which is, not unreasonable, in the literature, people have said it's our duty as caregivers to, inform our patients, and we can't hide stuff from patients. This gets a little bit moralistic. But there's an underlying point there, right? We can't just call something what it isn't just because we think patients want to hear it, right? We wouldn't say, look, this isn't an injection, even when it clearly is, just so the kid is less worried about it. The problem here is that saying this is cancer because a pathologist says it's cancer is at odds both with history and with our common understandings of what the word cancer means. So this on the left is the first description of cancer in recorded human history in a papyrus from Greece. It predates modern pathology by 3,000 years. So we've been discussing cancer for 3,000 years before a pathologist, Virchow, came along and said, okay, here's what cancer is. And what about our ordinary definitions of cancer? And this is even from a pathology textbook. The definition is about harm. It's about invasion. And whether this is in the Webster's dictionary, or what we go to as to the meaning of the English language: a malignant tumor of potentially unlimited growth that expands systematically by metastasis. So the idea of metastasis and growth is inherent in the ordinary meaning of the word cancer. So let's go back to John Epstein, because he really knows what he's talking about. This is a study he did. He looked at 14,000 whole mount RP slides, and as you can see, in the patients, out of those 14,000 cases, there were 0 cases of lymph node invasion. All 14,000 didn't have lymph node invasion. And the conclusion from one of our most eminent pathologists is that pattern 4 or 5 is required for metastatic disease. Pattern 3 can't metastasize. So we have this ordinary language definition of cancer as something that can metastasize and harm. And we have extremely good evidence, and one of our leading pathologists is saying that pattern 3 can't metastasize and harm. And it seems reasonable to conclude, therefore, that pattern 3 does not need to be described as cancer necessarily, that there is at least room for debate on that and room for people to disagree. One of the other arguments been made in the literature as why you have to call pattern 3 cancer is that, as you can see here, it shares many molecular alterations that are found in higher grade prostate adenocarcinoma. And they talk about the loss of P10 and GSTP1 downregulation and TMPRSS gene fusions. But the point is that these are also found in benign tissue. And to see from the evidence there, I mean, there's little studies showing how often you find TMPRSS fusion in BPH, or how often benign tissue you see P10 loss. And I think we all understand the biology of cancer, and we understand that there, as you go from BPH through high-grade PIN, through low Gleason, high Gleason, then METs, the further apart you get on this spectrum, the less shared molecular characteristics you have, but they're always shared. There are things that are common between METs and BPH, and between high-grade PIN and high-grade cancer, and so on and so forth. So one of the next arguments that comes up is, well, all right, yes, it can't metastasize, but yes, it doesn't have molecular features that are only found in cancer. But what about the basement membrane, right? The involvement of the basement membrane, no ifs, no buts about it. This is what defines cancer. And the fact is, it's just not true, right? So this is ductal carcinoma in situ, and this is in breast cancer, and we call this a cancer even though it doesn't involve the basement membrane. So if in the major female cancer we call something that is cancer even though it doesn't involve the basement membrane, I don't see why it's totally impossible to say that in the major male cancer, because it does involve the basement membrane, we have to call that cancer. Here's another really key point in this idea that, well, it's cancer, that's it, it's all over, is actually there's a lot of disagreement amongst the pathology community. So this was a survey that Scott Egener did, and look at that second row. It's true that only a minority of pathologists, about 1 in 6, support removing the designation of cancer from grade group 1 disease. But it's only 61% oppose and 24% are uncertain. It's not unequivocal that we need to call cancer. That we need to call Gleason 6 disease cancer. If there's room for reasonable people to disagree, we can then look to the practical effects. There's just one other thing that I want everyone to think about is, let's just imagine that in my previous slides, I'd proven without any doubt that Gleason 6 was indeed cancer, that it was distinguishable from non-cancer in very obvious ways, molecular hallmarks or whatever. Let's imagine, you know, a burning cigarette has molecular hallmarks of combustion. But that doesn't mean if somebody were to light a cigarette in a crowded theater that it's okay to yell fire. Right? It's true, but what happens as a result of doing that is you get panic and people get hurt. And this is essentially what we've been doing in prostate cancer for decades, is we're yelling fire in a crowded theater and people are panicking and getting hurt. Okay, so I've made the case that there's room for reasonable disagreement about whether Gleason 6 is cancer, and therefore I believe whether we call it cancer or not depends on the practical effects, the public health benefits of redesignation. I will now describe. There are many of them. So this is something we often hear from cancer patients, prostate cancer patients, is, you know, hearing I had prostate cancer was the worst day of my life. And there's a long history behind this. On the far left, Vince DeVita's book about cancer, he describes in the 1940s when his aunt had cancer, you couldn't even say the word. It was such a terrible disease that it was taboo. It scared people so much. In the middle, that's Shirley Temple. When Shirley Temple in the early 70s said, I have cancer and I'm being treated for cancer, and here's a picture of me in my hospital bed. The fact that someone would say this out loud was shocking. This is such a terrible disease. We don't even want to say its name. We don't even want to think about it. It's that scary. And even in contemporary culture, you know, there's a TV program called The Big C, right? We don't call cancer, we can't even say the word cancer. It's like Voldemort. It's that scary. And we know how stressful it is to get a diagnosis of prostate cancer because it's been documented that it extends to suicide. I mean, it's low, but it's definitely there. It's so emotionally difficult to hear that you have a diagnosis of cancer, even if it's low risk, that some men kill themselves as a result. Of course, this is the biggest problem, is that overtreatment is still way too common. These are US figures. So you can see even last year, this is from Matt Cooperberg's Aqua Registry, you had about 40% of men with low-risk cancer are still getting prostatectomy, brachytherapy, external beam radiation, or even hormonal therapy. And you've seen that I bolded the word low risk, because remember, this isn't Gleason 6. Right? So if somebody, remember, they have Gleason 6 and they have a PSA of 10.5, we can say, oh, you're intermediate risk, and go and treat them. And so some people say, well, you know, it's not really a problem because in Australia or in Sweden, you know, nearly 100% of low-risk patients are on active surveillance. And, you know, I want to know what proportion of patients with Gleason 6 disease are on active surveillance. Now, one of the reasons I'm showing a paper here is because everything that I'm saying is based on the peer-reviewed literature or on established principles of good medical practice. We know cancer is a scary word, and we have all this overtreatment. So let's go and ask patients whether the two are connected, and they are. The reason why patients are asking to get treated and leading to overtreatment is because of the word cancer, because the word cancer is so scary. I don't think that's going to surprise any of us who've sat in a room with a patient and heard them struggle with the treatment options for Gleason 6 disease. There's another interesting point is, let's imagine that overtreatment was no longer a problem, that, you know, almost everyone with Gleason 6 disease was managed conservatively. Would we say, okay, then that's fine, we don't have a problem here? I would still, even if overtreatment was not a problem, if the medical, you know, if urology got its act together, I'd still say we shouldn't call it cancer because of the social implications. And again, this is all very clearly documented in the literature. So about 20% of men who stop working when they get prostate cancer and don't start working again. And it's actually hard to get a job if you have a cancer history. I love this title. This is in the Journal of the National Cancer Institute, Life Insurance Coming to a Cancer Survivor Near You. Once you had a diagnosis of cancer, even if it was low-risk prostate cancer, you couldn't get life insurance. for so long that the fact that you might be able to is literally of news value. Lots of research on the effects of cancer on relationships, and it can be absolutely devastating. And this is an interesting one. If you have cancer, there's all sorts of effects on your medical care. And one of the most obvious ones that we see in our center is that you can't get experimental treatments for another cancer you might get. And this in the bottom right is a kidney transplant. We've just heard about this really tragic case of a young man who was dying and needed a kidney transplant. And it turned out that his dad was a good match. And the transplant was nixed because the father had been diagnosed with low-grade prostate cancer. Completely avoidable if we just had not called that Gleason 6 disease cancer. The other thing about our decision to call Gleason 6 disease cancer is that it is killing people every day. And the reason it's killing people every day is because men are dying of prostate cancer every day because they're not getting screened, and they're not getting screened because of overdiagnosis and overtreatment. So that's the arguments why we should redesignate Gleason 6 disease to a term that doesn't involve cancer. There's been a robust debate in the literature criticizing our ideas, and that's fine, but something very obvious has come up, is that everything that I've said it's either extremely obvious part of good medical practice, or there's peer-reviewed literature to support it. Pretty much every counter-argument is based on speculation, has nothing to do with evidence-based medicine. And here's just one example. This is a paper by Netto et al. And I'm going to give you some quotes, and you can see it's just speculation, right? Why should we retain a cancer label for grade group 1? So this is the first thing they say. If one were to drop the cancer label, adherence to intensive monitoring and the option to choose definitive therapy could be jeopardized. Okay, could be, might be. We don't know this. It's pure speculation. A redesignation may raise legal risks related to potential grading disagreements. I must admit, I simply do not understand why the disagreement between treat and non-treat is going to be any different legally than cancer versus non-cancer. But again, there's no evidence provided that this is the case. It's just speculation. One can anticipate a significant increase in equivocal diagnoses and repeat biopsy. Again, pure speculation. The fourth bullet is particularly interesting, and you see it in all of the literature that criticizes the idea of redesignation, which is, yes, I know we've got a problem with overtreatment, but we can solve it. We can get there. All we need is more education. And this is a problem that we've had for decades, and it's not going away. And we're doing a lot of education all the time. And as I've shown you, things are changing very, very slowly. The other interesting thing about this argument is it's completely contradictory and inconsistent with the first argument. So critics of the idea of redesignation say, wait a minute, if we drop this cancer label, all these patients in active surveillance would simply drop out, then end up dying of their cancer, and there's just nothing we could do about it. It would be a disaster. People would die as a result. Oh, but this big problem we actually do have now, not a problem I'm speculating in the future, but something that is demonstrated to happen now, we can just educate our way out of that. To me, that is a highly inconsistent argument. There is, I believe, an actual decent argument for keeping the designation of Gleason 6 as cancer, and unsurprisingly, it was made very nicely by John Epstein. And his basic point is, yeah, true Gleason 6 cannot metastasize. We've seen that. But my study that I did on that as John Epstein was based on sampling the whole prostate, and we typically diagnose based on a biopsy, and that's just a sample, and you can't be sure you have higher grade. So that's not a bad argument. This is our pathologist whose counter argument is saying, as a pathologist, I'm going to diagnose you based on what I see on the slide in front of me, and not on the shortcomings of the diagnostic procedure. And I think that's absolutely right. when in medicine do we say, I'm going to diagnose you with something, even though I don't see that you have it, but just in case you do indeed have it? Right? We know that diagnostic tests are not perfect, that they have a certain sensitivity and specificity. And we know this even in urology, because as you know, men who have positive cytology, and we do cystoscopy and can't seem to find a tumor, we do sampling. We sample the bladder, random sample, just as we do in prostate. But we don't say, well, we didn't find anything, but it was only a random sample, so we're going to say you have cancer, even if you don't. So there's a whole bunch of arguments there that suggest that redesignation is an option, right? It's reasonable scientifically to say that Gleason 6 disease is not cancer. Clearly, if we did that, the benefits would far outweigh the harms. So I guess what you want to know is, well, how would that affect me as a surgeon, as a pathologist, as whatever? There's a little sort of, to start this off, is just a little tweet. I was talking with a urologist and said, yeah, great idea, Andrew, but let me tell you about this one patient. I had an active surveillance and everything looked fine. And then suddenly everything went crazy after 1 year. So, what about that? And I said, well, tell me, what would you have done differently with this man if you'd said, you have a pre-malignant lesion, it's not cancer, it's pre-malignant, and I'm going to watch you carefully. And the doctor said, yeah, I take your point. I wouldn't have done anything differently at all. Let's go back to our mission statement, if you like. What is the effect on your practice? Is that you will be able to decide what you do based on best evidence and established principles of good medicine without being influenced by this word cancer. So what does that mean in principle? Can you treat? So this is one of the things, well, wait a minute, if you don't call it cancer, you can't treat it. And they'll, what about a guy with high volume disease and symptoms of urinary obstruction of BRCA1? That's an obvious case you'd treat, and you can't. Well, I don't see why that's the case at all. We routinely treat and operate in our hospital patients who don't have cancer. A prophylactic mastectomy is an obvious example. Some of you may know that we even remove the stomachs of people who don't have cancer but are at high risk genetically for a gastric tumor. Can I rebiopsy a patient? In active surveillance, we do the confirmatory biopsy, but how can I do that if they don't have cancer? Well, of course, you'll often do that for high-grade PIN, and high-grade PIN isn't cancer. What about focal therapy? Can I do focal therapy on a Gleason 6 tumor if it's not cancer? Well, my view is actually, yeah, it makes it easier for you to do that. Many of you may know we had a kind of decade-long row with the FDA about focal therapy. And my own view is, if we'd gone to the FDA back when and said, here is a really good treatment that kills off pre-malignant lesions before they become cancer, it would have been much easier than what we tried to do, which was to say, here's a good treatment for a cancer that doesn't need to be treated. And obviously, treatment of pre-malignant lesions is absolutely standard in cancer, whether we're talking about cervical cancer or colon cancer, or obviously one would be for melanoma, abnormal nevo. Can we do active surveillance, right? Well, even though they don't have cancer? Well, of course, this is, again, absolutely routine. I have a member of my family actually who had a colonoscopy recently and had lots of polyps. And they said, you're at high risk of cancer, so we need to see you back soon to have another colonoscopy. What about the path report? The path report doesn't change, other than if it's 3+3, you give it some other name than cancer. But everything you do on your path report can stay exactly the same if we think that is what is supported by best evidence. Whoa, what about the registries? Wait a minute, the number of cancers, this graph will totally change, and the number of prostate cancers will collapse. Well, it could not. It depends. We could still include Gleason 6 disease in the registry and explain why we're doing that. It's fairly standard to the registries aren't, what's put on the registry is not dictated 100% by the word cancer. So let's just, to sum up, there's, we can have lots of interesting academic debates, right, about the molecular hallmarks of cancer. Or is it undersampling? Can we call something cancer if we haven't fully sampled it? But today in our clinic, we will no doubt, there'll be a man come in who is distressed by erectile dysfunction, having that being caused by a cancer that never would have affected him. And we're also probably today going to see in our clinic a man who, with advanced disease, because he was never screened, because his primary care physician made a totally understandable decision, or the man did, not to screen because of the harms of overdiagnosis and overtreatment. And we could have avoided both of these things simply by redesignating Gleason 6 disease as non-cancer. So that's the end of my talk, and I'd be very interested in having discussions on that.